If you've ever stood at a pharmacy counter wondering whether to pick up a medication or pay a bill, if you've ever delayed a doctor's visit because you were afraid of the price, if you've ever gotten a medical bill and thought, I have insurance, how is this still happening? Today, we're talking about one of the most debated ideas in American health policy, and that is single-payer healthcare reform. Now, a fair warning, this is not a quick topic. It's very emotional, it's personal, and it's deeply political. But in this episode, we're not about party loyalty. It's about systems and trade-offs, because every health system is a set of choices. Here's what I want to do today. I want to define what single payer actually means, because the phrase just gets thrown around very loosely. Explain why the U.S. Healthcare system costs so much and where the money goes, and also walk through how single payer could work in the United States, whether that is the financing, the benefits, provider payment, and transitions. I also would like to see if we could address the most common concerns: taxes, wait times, quality, innovation, physician pay, and choice. And we would like to end our discussion today with practical steps: what you can ask for, what you can advocate for, and what you can do right now. So, let's start with a very grounding statistic. In 2024, the U.S. health spending reached about $5.3 trillion, or about $15,474 per person, which averages about 18% of the national GDP. And that's not just a lot. That's the context for everything we're about to discuss today. Once again, another quick disclaimer. I am sharing policy analysis and publicly available data. This is not medical advice, and it is not financial or legal advice. If you have a personal coverage issue, please talk to a trusted clinician, a benefits manager, or a patient advocate. Also, most important of all, language matters. When people hear single payer, some hear security, some hear government takeover, some hear finally, and some hear never. My goal today is to be honest about what single payer could fix, what it will not fix, and what it would force us to decide as a country. So, let's begin with this question. What does single payer mean? Let's define a couple of terms. What single payer is at its core, single payer means one public entity. Usually it's the government, and that will act as the main insurer. It'll also be paying for medically necessary care for everyone and replacing most private insurance for core benefits. In most single-payer proposals, hospitals and clinics are not owned by the government. Doctors and nurses still work where they work. The single part is mainly about financing and payment, not necessarily about government-run hospitals. What single payer is not. A single payer is not the same as a public option. A public option is the one where one plan competes with private plans. Medicare Advantage is not necessarily single payer. That's publicly funded program, but it's privately administered insurance with private health insurance companies taking the lead. Single payer is not the same thing as universal coverage. In universal coverage, that can exist with multi-payer systems like Germany or the Netherlands. Single payer is one route to universal coverage, but it's not the only route. And why this confusion matters is because debates go sideways when one person is defining single payer as everyone gets covered, while another is attacking it as government owns everything. So for our discussion today, single payer equals one primary public payer for essential health benefits covering everyone. So, in the United States, how do we pay now? So before we can start arguing about changing the system, we really need to understand the current one. In the United States, we have a fragmented multipayer model. We have an employer-sponsored insurance, which is now the biggest private channel. We also have individual market plans with the Affordable Care Act exchanges. We also have Medicare, which usually covers everyone above the age of 65 and everyone that is on disability, and also folks on end-stage renal disease dialysis treatment. Then you have Medicaid and CHIP, which stands for the Children's Health Insurance Program. And Medicaid is a combined state and federal collaboration. It is usually based on income levels. Then you also have the VA, the Veterans Affairs, and the military health systems. And then you have a lot of people that are sort of fluctuating, moving in and out of these buckets over time. And the money comes from everywhere. For example, they come from payroll deductions, from employer contributions, from income taxes, and other taxes. They also come from premiums. Also, another source is deductibles and copays. And there's always the surprise bills and out-of-network charges. These are less than before, but they are still present. And of course, you still have odd out-of-pocket spending, which in 2024 was about $556.6 billion. So when someone says single payer would raise taxes, the honest response is yes, but it might also do something else. It might also replace a lot of the spending that already acts like a private tax, such as premiums, deductibles, and employer contributions that come out of total compensation. See, the question isn't do we pay? The question is how do we pay and who bears that burden the most? So we've actually ran a whole episode about this topic. So this next segment, we're going to try to keep it a little concise. So please do, when you get a chance, listen to our episode devoted to this next question, which is, why is the United States healthcare system so expensive and costly? So remember, this is the fundamental issue specifically related to single-payer healthcare system, but also this episode, because if we don't really agree on the problem, the solution will never really make sense. So, on average, the U.S. spends more than its peers, way more. International comparisons consistently show that the U.S. spends far more per person than any other wealthy nation. The OECD has described U.S. spending with very high per capita spending compared to its peers. And yet, despite all that, spending more does not automatically translate into better outcomes. So where is the money going? Well, first off, prices. Prices. Many analyses point to higher prices in the United States, whether that is for hospital services, physician services, pharmaceuticals, and administrative services, more than simply just saying too much utilization. Single payer, in theory, uses purchasing power to negotiate or set rates. Another aspect of where money is going to, administrative complexity. Administrative complexity. This is one of the clearest differences between the United States and other international healthcare systems, and that is the administrative burden of fragmentation. The Commonwealth Fund has argued administrative complexity is a major component of the U.S. excess spending compared to other countries, and this is attributed to substantial portions of excess spending, to insurance-related and provider administrative burdens. Health Affairs has also described and discussed administrative spending as a significant share of healthcare spending, with estimates spanning a wide range in the literature. Here is the most important nuance. Single payer doesn't magically eliminate administration. You still are going to need claim processing. You're still going to need fraud prevention. You will still need to focus on quality measurement. And of course, you cannot keep your eye off of oversight. You're going to still need oversight. But here's the catch. Single payer can potentially reduce eligibility churn, prior authorization complexity. Single payer can reduce multi-plan billing, And it can also address a duplicative or duplication contract. So, the next thing to look into is a system built around billing, not care. That's the major issue with the United States healthcare system. Because here, healthcare delivery and healthcare billing are almost two separate industries. And this is where people feel the insanity. You have coding battles, coding specifically regarding diagnoses and procedures, denied claims, opaque pricing, and endless phone calls. Insurer denies a claim or a prior authorization delays a medication. That friction isn't just abstract. It lands specifically on the shoulders of clinicians, and it lands specifically on the shoulders of patients. Let's look again at the spending scale. Okay, let's come back to it because $5.3 trillion in 2024, that's the pool of money that we're rearranging. That is literally the third biggest economy if it were to be by itself in the world, right after the United States and China. So single payer is, in a sense, a proposal to change the plumbing of that $5.3 trillion. So we're going to be looking at consolidating payment, setting more standardized rules, and using scale to bargain. So what would a single payer look like in the United States? Now, this is where it gets a little bit complex, and this is where we really get to the architecture of what a single payer system in the United States would look like. So first off, there would be coverage and benefits. Most single payer proposals include covering primary care and specialty care, covering hospital services, covering preventative care, and also looking at maternity and newborn care and not ignoring mental health and substance use treatment, while at the same time trying to include prescription drugs and hopefully also including dental, vision, hearing, and long-term services and supports. On a practical level, which sounds outstanding at this time, the big shift is that no networks for essential care or at least vastly fewer constraints. Okay. Next, enrollment and eligibility. So single payer usually means automatic enrollment at birth or residency. No employer plan selection. No annual open enrollment scramble where people are just dying to get in quickly in that short defined time period. No losing coverage when you change jobs, which does sound quite nice. I'm not going to lie. That also does sound very refreshing and also can give you a security guarantee and will not tie you down to places of employment that you're not necessarily content with. So the not losing coverage when you change jobs, that is one of the biggest quality of life improvements that will never show up on a hospital bill, but it will change lives. Another key component of single payer would be provider payment. How do doctors and hospitals get paid? There's a few models. Nothing is set in stone, obviously. Number one is the ever consistent fee for service, but with standardized rates. Doctors and hospitals bill for services, but rates are standardized, and more importantly, those rates are made much more simpler. Another key proposal is global budgets for hospitals. You see, hospitals get a yearly operating budget, similar to how we fund your capacity instead of billing each item. And another model that has actually been already kind of in utilization these days, which is capitation or salaried models. For some services in this model, the system pays per patient per month, or the providers are salaried. In the real world right now, it's usually a mix. And the trade-off, to be honest, is that standardized rates can reduce extreme pricing and improve predictability. Now, if the rates are set too low, you will obviously risk access problems. If the rate is set too high, you lose savings and you may fuel overuse. Another aspect to look into, prescription drugs, which do play a significant role in patient care. You see, single payer typically emphasizes national or centralized negotiation. There will be a set formulary for the plan as a whole. They also can look at potentially reference pricing. And of course, this is always going to be a major political battleground, but it is going to be a major lever. Also, financing. And that's the concern with single payer. How are we going to finance this system? Well, of course, taxes will go up. Well, is that so? Is that really true? Because remember, in a single payer system, you're really going to replace premiums, right? First off, so people won't necessarily have to pay outstanding premiums. You're also going to be replacing employer contributions. Well, your employer will not necessarily have to contribute more out of their own pockets. You're also going to be replacing many deductibles and copays with usually a combination of payroll taxes and income-based taxes and or other revenue streams. But here's the key messaging point. Most households don't experience health spending as a line item in the GDP. Instead, they experience it as payroll deductions, as surprise bills, and anxiety, right? We're all anxious. Oh man, what's my next bill going to look like from the hospital? Oh man, I had this lab work done for autoimmune disorder. How is that going to be? Burdensome, more anxiety. So the single payer argument is essentially, let's just trade all of this chaotic, regressive, unpredictable payments for the opposite, predictable, progressive, standardized financing. Now, people will say, well, the counter argument to that is also real. When the payment is a tax, it's unavoidable, and trust in the government matters. So remember, political feasibility hinges on transparency, it hinges on independent oversight, and it also hinges on a transition that doesn't destabilize care, right? So either way, there's arguments to be made on both sides. But at the end of the day, you really have to ask ourselves, we're spending all this money anyhow. Why don't we just go ahead and standardize it? But these are some of the questions, and these are some pretty big questions that people ask. First off, will I lose my doctor? Under a well-designed single-payer plan, you might actually gain access to more providers because networks now will matter less. Now, there is risk involved, and this is the risk. If the provider rates drop too much, some providers may limit how many patients they take or opt out. This is something that we already kind of see right now in Medicaid and also in some cases with Medicare. We do have a certain number of health systems and a certain number of providers that already don't take those insurances, but we also have limitations or caps on how many patients providers can see, specifically when regarding Medicaid. So the real question isn't single payer means losing your doctor. The question is, how will we set payment rates and manage capacity to continue encouraging providers to see patients? Another question that people always worry about when it comes to single payer system. What about wait times? See, wait times are not unique to single payer. Even right now in the current system, Americans wait too long, especially for specialty care in some regions, especially for mental health. That's a national issue these days. And also for procedures when costs or prior authorizations delay care. You see, the single payer risk is rationing by time. The current U.S. system often rations by price and coverage rules. So every system kind of rations in its own different fashion. The question now is which form is more ethical and critical and more tolerable? Is it time or is it price and coverage rules? Another question to look at, will quality go down? Quality depends on a variety of different factors. It depends on staffing. You need to have adequate staffing in order to be able to provide patient care. Quality also depends on capital investment. You're not going to basically be able to make yourself healthy if you're only willing to spend a penny instead of $1. Quality also depends on clinical standards. And quality also depends on payment incentives. A single payer model can improve quality by making preventative care easier to access, by standardizing evidence-based coverage, and by reducing treatment delays tied to the insurance churn. But quality can worsen if budgets are too tight, if the workforce shortages are not addressed, or bureaucracy gets pretty heavy. Another question to look into with single-payer system: will innovation die? People worry that if profits shrink, innovation shrinks. But a lot of U.S. innovation is already actually funded through a mixture of other funding sources. Most important of all, public research, academic medical centers, the National Institute of Health-supported work, and broader ecosystems. Because you see, my friends, the deeper truth is that the single-payer system changes where profits live. It doesn't necessarily erase innovation, but it might reduce certain kinds of innovation, especially those tied to billing, complexity, or market segmentation. And of course, another question to look into is, and this is exactly applicable to the United States of America, isn't the U.S. just too big and diverse? Yes, it is. The United States is big, it is complex, but complexity is not a reason to avoid reform. It's a reason to design a transition much more carefully and to do so with much more thought put into how we're going to design that system. So, now that we looked at all those questions to ask regarding single payer, here's the hard part. If you want the honest reason single payer is difficult, it's not the math. It's the transition. Because you see, what changes quickly, insurers shrink dramatically for core benefits. Employer-sponsored insurance shifts. Billing departments change. Benefit managers and intermediaries shrink. That's jobs. That's lobbying power. And that's disruption. And that disruption is what must be faced. You see, a realistic transition might actually lower Medicare eligibility age over time, add children and young adults first, or allow state-level pilots on the state-based reform, while at the same time building national infrastructure. And you would need a lot of different resources, but you would need workforce strategy, first and foremost, specifically by enhancing primary care strategies to increase primary care workforce, stabilizing the nursing workforce, and also enhancing the workforce involved in mental health. You would also need rural hospital stabilization plans. That is one key thing to look at over the course of the next few years here in the United States, specifically the ability of rural hospitals to stay afloat despite all of the challenges that they face. You would also need clear provider payment guardrails, and this is where good policy also is something to keep an eye on, because you would also need strong anti-fraud systems. This is not a slogan. Making a slogan isn't going to get us there, but implementing it thoughtfully is what's going to get us there. And so, in conclusion, we are asking for a call to action. Our current system does not really work. We are spending the most compared to everybody else in the developed world, and yet we're having one of the worst in terms of outcomes compared to all of our peers. So we need to do something, and whether that is single payer or a different system, we need to have these conversations. And so let's end where we started, with what reality is today. In 2024, the United States once again spent $5.3 trillion on healthcare, almost $15,474 per person, about 18% of the national GDP. That isn't just a statistic. It represents care delivered, it represents care delayed, it represents lives that were extended, but it also sadly represents lives that have been lost. Plus, on top of all this, you add in a massive administrative and financial system that millions of people navigate every single day. Single payer is one proposal to simplify the system, to expand coverage, and leverage national purchasing power. It could reduce administrative complexity and improve coverage stability. It could also create some new risks: political vulnerability, budgeting fights, and access constraints if the system underfunds capacity. But here are 3 things you can do, regardless of where you land on this argument. First, ask better questions during the course of public debate. Not if this is just socialism, but how does it pay providers? How does it control prices? How does it build capacity? What does the transition look like? Second, demand clarity about the costs. Premiums, deductibles, out-of-pocket spending. What are you paying for now, really? Third, advocate for specific steps even if you don't support full single payer today. And these are pretty simple: standardized billing, stronger drug price negotiation, less of the instability and less churn associated with the insurance companies, broader coverage, and fewer barriers to essential care. Because whether we choose a single payer system or not, the status quo right now is already a choice. The problem is that it is not working. We know that. And it's an expensive one. So, thank you for those that are taking the time listening to us today. If this episode helped, please share it with one person, one clinician, one policymaker, or a patient, or even a friend. Thank you so much.